I do want to talk about a specific female-centric lens for women over 40, not because your tendons are worse, but because the inputs to the tendon, like tendon load, tendon recovery, and tissue behavior will change around this age. And if I asked you to tell me why you think that is, you could probably tell me. There's a couple of few major drivers colliding, right? At the same time, we have perimenopause and menopause, right? So we have these massive hormone shifts to which tendons and ligaments, they have estrogen receptors, and estrogen influences tendon strength, tendon stiffness. It also influences ligamentous laxity or lack of it. And then, hormones can meaningfully change connective tissue behavior across the lifespan. There can also be, for women over 40, almost like a life fitness mismatch and tissue capacity. We have like kids, work, we're not recovering as fast, and we're not giving ourselves more recovery. And then suddenly we're returning to intense training because somebody on Instagram told us that we have to lift heavy shit, right? So I would say when we're looking at some certain anatomical regions, they disproportionately affect women. So, and I'll say like there's two really big ones, but I want to talk about a bunch of them, but the lateral hip and the shoulder. So we're going to talk about those now. And then the other thing I do want to just mention is that there are generally, if you're not thinking about your tendons strategically, age-related degenerative changes, right? So our tendons, our tissues as a whole generally remodel slower as we age. So the margin for those sudden spikes really shrinks. So as you get older, just like me, I hate surprises more and more and more. So let's talk a little bit about some of the more common ones. As I mentioned, lateral hip pain, often GTPS or gluteal tendinopathy, very, very common for women 40 plus. If I had to choose one signature tendon problem for women, it's this one. It's lateral hip pain. It's often like kind of grouped into a bigger clinical picture called greater trochanteric pain syndrome. Okay, who cares? It's just like lateral hip pain. Okay, it involves like the glute medius, glute minimus, and the tendons of those two muscles. And it's widely we see this very commonly. Anyone who has a musculoskeletal practice, any woman over 40 has come in calling it like hip bursitis, or there's some I can't sleep on the side of my, at night I can't sleep. It is usually, when we think about the mechanism, what's actually irritating the tendon. This one's not just weak glutes, although weak glutes do play into it. Again, it's about load and compression. So the glute tendons, they all work in a variety, like they do a lot of things. They extend the hip. They help stabilize the pelvis in a single leg stance. So if you were to stand and just lift one knee up, let's say, the contralateral glutes have to work so that your hips don't dip. Anytime you're walking, going upstairs, running, standing on one leg to put pants on, like your glutes are working. When your hip falls into adduction, so think like the hip dropping inward, or when you load the hip while it's compressed, the tendon can get both that tensile load and compressive irritation. So that combination together is usually quite notorious for flaring symptoms. So, and then you add on like prolonged, positions that compress the tendon. So if you're like side lying, sleeping on your side, or you're sitting with your legs crossed, then you have this like kind of predictable cycle that happens. So for women who are over 40, obviously stop feeding the compression while you rebuild the capacity. So sleep with a pillow in between your knees, avoid side lying on the painful side if you can. I would also say to temporarily avoid long stretches into the hip adduction. So if you're looking at like deep ITB, iliotibial band stretches, those can actually be a bit provocative. I would really work to strengthen the abductors. So those are you have the anterior and posterior fibers of the glute medius. You have the tensor fasciae lata, which is almost like that tumor. It's like, when in lean individuals, it almost looks like a tumor at the top of the head, at the top of the leg, to which I love to say in my best Arnold voice, it's not a tumor, it's a tensor fasciae lata. So we have Thank you for listening to that, and hopefully you laughed. But yeah, so we have like the tensor fascia lata, as well as the glute abductors that really need to be strengthened. So it's the same kind of thing, like isometrics, low irritation in neutral, progressing to weight bearing work, and managing your load. Right, things like step ups and lateral step ups as pain stabilizers. The goal here is to create strength, not just burn. Okay, so we know the difference between strength and burn, right? So the difference between strength training and Pilates. When you do like 1,000 reps, that's muscle endurance. That's when you feel a burn. That's not what we're after. We're actually after strength. So when on that abductor machine, I like to call it the bad girl machine. At the gym, because you're sitting with your legs together and then you open them and you try to open them as wide as you can. That's your bad girl machine. We want to be actually working that as much as we can to failure, because that is going to really help stabilize and create strength in the hip. So often, again, so thinking about, do you feel worse at night after a strength training session? That will help you sort of dictate your load. Another one I'll talk about briefly is the rotator cuff tendinopathy and tears. So this is kind of like the second biggest category for women. It's the shoulder, rotator cuff tendinopathy, and even rotator cuff tears. These increase with age, and there's, when we look at perimenopausal and menopausal women, you can have structural changes, again, without obvious symptoms. So pain is never that perfect damage meter. Like you could have changes because you have poor form, or you're overloading it, or your maximum recoverable volume is being surpassed. But you may not know it until we get like some kind of tear or some kind of snap. So in terms of pain, often what happens, again, load management. So sudden increase in overhead work, or you're doing a new strength program, you're doing more push-ups, all of a sudden you're starting to use kettlebells, you're doing pull-ups. You can also have, for a lot of women, degenerative and we'll say cumulative micro trauma. So you've had years of repetitive shoulder use, slower remodeling, poor technique. The other really big one is like thoracic stiffness. So like your thoracic spine is your mid back, because we're all sort of sitting like the hunch of, what's the guy's name from Notre Dame? The Hunchback of Notre Dame. We're all sitting like that over our computers in that kyphotic or that flex position. We lose the extension. We lose that sort of thoracic mobility. And that will affect our scapula. So if you don't have really good thoracic mechanics and the scapula doesn't like rotate well when you're lifting your arms up, the rotator cuff can get overloaded during elevation because your scapular mechanics are a little bit funny. So rehab considerations here is, again, don't rest forever, reduce the irritant, right? Manage the load. You want to keep your capacity work. Keep your presses, like your overhead presses, with modifications. So you can change, like if this is irritating, if you're watching this on video, my hands are facing forward, change the grip. So if you want to bring it into more of a neutral or a Swiss grip, if that's helpful, you can change and load the rotator cuff a little bit differently that way. And then I would say build cuff capacity and scapular support together. So working on external rotation, strength and endurance. So I did an Instagram video of this not too long ago, but if you're lying on your back, external rotation is if your arm is at 90, you're just going to open up all the way, and hopefully you can actually rotate a full 90 degrees and even more so. That's external rotation. And internal rotation would be the opposite. So lying on your back and then bringing your arm all the way down, and hopefully you can get your forearm on the floor as well. The other thing that's really important for women is like scapular retraction. So being able to, I always say, bringing your shoulder blades back and down on your back. And then again, you want to be doing isometrics, slow tempo, controlled range. We want to be moving, even if you can't do full overhead presses, let's say, maybe you do like a partial rep, like a long length partial. So we want to be very, very careful with that. So those are kind of the big two. I would say other ones to consider. We talked about lateral epicondylitis, or like the tendon, like tennis elbow is what it's often called. It doesn't just come from tennis, but a lot of women over 40, like that 40 to 49, much higher incidence of tennis elbow than in men. And this is usually, we take up pickleball, we're taking up tennis. It's that repetitive gripping, that wrist extension under load. So you get this, you take up a new racket sport, and all of a sudden the outside of your elbow starts to get a little bit funny. You'll notice it with like lifting a kettle or, shaking hands, opening jars, all these things are going to irritate the lateral epicondyle. So same considerations as before: manage the load, isometrics, heavy and slow resistance, right? And then we want to modify the grip if we need to, and we got to wait, unfortunately. I will say the other thing that's really helpful for the lateral epicondyle in particular is using straps for lifting. Your grip will always be the limiting factor for muscle anyway, so I would definitely think about investing in a pair of grips. I have, what's the brand that I use? I don't even recall. I think they're called Cobras, maybe. Lots of great brands.